I am a fellow in integrative medicine, and I'm a certified acupuncturist. I've been in the community since 2001. I was an associate professor at the University of Colorado. I was in private practice, and I currently work for Colorado Complete Health for Women. Before I was a physician, I was a teacher. I taught first grade, third grade, and college. And I truly feel that my purpose in life is to be a healer. I look at myself as a modern-day medicine woman, and I love empowering women on their journey to health and wellness through a patient-centered relationship. So today, I'd like to talk about a topic that affects 50 to 75% of the population, and most of us are too embarrassed to talk about it, that of urinary incontinence. I'll give you some background, I'll provide some treatment options, and specifically talk about the MonaLisa Touch. So, do you accidentally lose urine when you cough, sneeze, run, jump? Do you feel like you have to urinate all the time? You gotta go. Do you get recurrent urinary tract infections? Do you have vaginal dryness, burning, pain with intercourse, or frequent vaginal infections? You may have urinary incontinence. So there are lots of different definitions of urinary incontinence, but I'm going to simplify it to 3. Stress urinary incontinence is involuntary loss of urine with effort or physical exertion, with a sporting event, coughing, or sneezing. Then there's urgency urinary incontinence, and that's when you have involuntary loss of urine that's associated with urgency or a sudden, compelling desire to void that you can't defer. And then there's mixed, where you have both involuntary loss with effort and with urgency. Well, what else could it be? It could be an infection. It could be a urinary tract infection or a vaginal infection. It could be something that you were born with, congenital, things like an ectopic ureter or a fistula that get worse over time. Could be something that's functional, neurologic, if you have multiple sclerosis, cognitive issue, a psychological issue, or a physical impairment. It could also be something in the environment or some type of medication that you're taking. It could be a beta blocker, a calcium channel blocker, a diuretic. And interestingly, systemic estrogen and progesterone sometimes increase urinary incontinence. Caffeine and alcohol can also affect it. And then there could be a metabolic issue, things like diabetes. So it's really important that you see your practitioner, or myself, to get it adequately diagnosed before you have treatment options. So a lot of people are really worried about, oh my gosh, what is going to happen when I go to the doctor and talk about urinary incontinence? So I thought I'd talk about it a little bit. Hopefully, your practitioner will sit down with you and discuss your symptoms. What started it? What makes it worse? What makes it better? How severe are your symptoms? Do they affect your activities of daily living? Do they make it so that you don't even want to leave the house because you're afraid of having an accident? Then we may look at your past medical history. Do you have diabetes? We'll look at your surgical history. Have you had a hysterectomy? What about a bladder lift? And then your obstetrical history. Did you have a C-section, forceps? We'll again review those medications that we talked about. And then treatment options. What have you used in the past and how effective has it been? Then we'll do a physical examination. So we'll do your weight, and if your weight is a little bit over the BMI, you're probably at increased risk for incontinence due to sheer gravity. We'll look at pelvic relaxation. Is the bladder and the cervix coming down and out the vagina? We'll also screen for that urinary tract infection and then maybe the vaginal infections. Then we might do these specialized tests where we'll have you urinate, we'll have you come back in, and we'll actually use a little catheter and see how much urine is left in the bladder. It's called a post-void residual. If it's less than 150, then it's probably just urinary incontinence. We also may have you do a cough test. That's where you fill your bladder up, and then we either have you lay down and cough and see if you lose some urine, or even standing up and cough and see if you have some leakage. We also may put a little Q-tip in the urethra and see how much it moves when you bear down. And then hopefully we'll get you dressed. We'll have you come back in and talk about some treatment options. What works for you, and what do you want to start doing right now? So the good news is you're not alone. Believe it or not, 25% of women who are in high school and college actually have incontinence. 44 to 57% of middle-aged or postmenopausal women have issues with leakage. And if you make it to 75 to 90, 75% of us will have incontinence. About a third of us will have incontinence after we have childbirth. And if you have it initially at 4 months, you're probably going to have it again. If you had it 3 months, you'll still have it at 4 years. And some of us are really lucky. We get to have both. 15% have both urinary and stress incontinence. So risk factors for when you're pregnant to get incontinence. If you leaked urine before pregnancy, you're probably going to leak urine after. If you had a long labor, greater than 8 hours. If you're a little older when you deliver, 30, or especially if you're 40. And then there's the instrument deliveries. That's forceps or a vacuum. You have about a 32% chance of incontinence versus just a regular spontaneous delivery at 28, and then a C-section at 15. So a lot of women were undergoing primary cesarean sections to try to prevent relaxation and incontinence. But if you look at the 6-year data, it's about the same, 38% for vaginal deliveries and 33% for C-sections. Well, why does this happen? We think that it must be something that we did. It's something wrong. But it's just physiologic. If you've had a child, you might have some incontinence. You have weight fluctuations up or down. You might have some leakage. And then there's the dreaded hormonal changes. If we're perimenopausal or postmenopausal, again, it may be that we have it more frequently. Pelvic floor dysfunction caused by relaxation is really if your bladder is coming down, you might not be able to completely empty it. So some women actually push on their bladder to be able to completely empty your void. And it's really all due to altered metabolism of connective tissue. With decreased collagen, elastic tissue, and blood vessels, we just have inadequate support. So remember, I'm a teacher, so I wanted to take us back. Here's our anatomy here, and I wanted to show you how close things really are. So here's your urethra, where you pee from, and your bladder. Here's your vagina, the uterus and cervix, fallopian tubes and ovaries, and here's your bowel. And then looking at it from the front, people are like, oh, I just don't know what it looks like down there. But this is the opening of the urethra, where you pee from, and this is the vaginal opening. And this whole thing is called the vulva. So this is what inadequate tissue looks like. Here you can see this is really thin epithelium, and here there's really no connective tissue, no collagen or elastic tissue. It's all fibrinous tissue. But if we had adequate collagen and we could return it to it, this is what your epithelium would look like. Nice and thick. All these little areas here are filled with something called glycogen that decrease your risk for infection. And then down here we have lots of collagen, and you can see right in here, this is actually blood in blood vessels. So how do we get that, right? So treatment options. There are behavioral and lifestyle modifications actually decrease your symptoms by 50%. If you lose 8% of your body weight, you will find that 47% of your symptoms might just resolve. Then there's bladder training, and that's where we have you void on a certain schedule, and we try to spread that schedule out. And then there's dietary and fluid modifications. Believe it or not, certain foods actually irritate your bladder, things like citrus. And people forget that tomatoes and tomato paste can be citrus, and that can aggravate your bladder. Some people it's caffeine or dark chocolate. And then there's fluid management, where if you're someone who gets up in the middle of the night and you gotta go 2 or 3 times, we might actually advise you to stop taking in fluid around 6 p.m. Then there's the dreaded Kegels, or pelvic floor exercises. There are lots of different ways to teach women how to do this. The best way that I have found is that where you hold back gas, you actually want to squeeze your anus. Try not to incorporate your buttocks, just your anus. And no one should know you're doing it. So you want to squeeze and relax and squeeze and relax. But like all muscles, you need to do it. You either lose it if you don't use it. So if you're having a hard time isolating those muscles, we have wonderful pelvic floor physical therapists that can help you find those muscles. They sometimes use trigger points and sometimes will also use electrical stimulation. Some women use weighted vaginal cones to help, but despite what Gwyneth Paltrow says, please do not use a jade egg. It is very porous and it increases infection. Then there's these things called occlusive intravaginal devices. So I used to tell my avid runners to use a super tampon. But now, Poise has come up with a specific tampon called Impressa. And I'll show you what that looks like in a minute. And then there are pessaries. They are silicone little devices that hold things up and in and can help with incontinence. And finally, there's pharmacological medications that can be used. Estrogen can be very helpful. It comes in a cream, a tablet, or a pill. And I strongly advise you to use bioidentical estrogen if possible. Premarin is a conjugated estrogen, and it comes from horse's urine. So there are over 200 different compounds, estrogens, progesterones, and androgens, most of which your body has not seen. So I strongly suggest that you use a bioidentical. Now the creams can be really messy. You take the applicator out, you pull it back to a certain level, you put it in, you cross your legs because you got to disassemble the applicator and wash it out and put it by the sink before you go to bed so that it doesn't kick up for the next day. So adherence is pretty variable with that. I have found that most of my patients really enjoy the E-string because you put it up into the vagina, there's constant release of estrogen, and it lasts for 3 months. And it really does help with incontinence. Then there's the overactive bladder medications, the antimuscarinics, the oxybutynin or the Detrol. And then there's the new Mybetrix that people use. So here is that little estrogen cream with the applicator. Here's the little Impressa tampon, and these are pessaries. Now if we want to get more into treatment options, there are things like Botox injections. So a urogynecologist or a urologist oftentimes will use a cystoscope, which is a camera that goes through the urethra, and they'll inject the bladder base with Botox. 27% of women are completely continent, but there are issues with urinary retention, incomplete bladder emptying, and urinary tract infections. Then there's something called urethral bulking agents, and those are primarily used for women who have intrinsic sphincter deficiency or do not have a hypermobile urethra. There's really no good data on it, and you have to use it over and over and over again. But if you have moderate to severe incontinence, you will probably end up with a surgery. And surgery can be very effective, 60 to 90% effective. The question is, how long does it last? And the data shows about 10 years. Anytime you have an invasive procedure, you do run the risk of bladder injury, voiding dysfunction, obstruction, pain, and then obviously mesh erosion. And then there's neuromodulation. There are actually stimulators that we can put under your skin and activate S2 and 4, and that helps with incontinence. And then there's a percutaneous tibial nerve stimulator called Urgent PC. And what I really like about this one is it uses acupuncture points. It uses spleen 6 and kidney on the bottom of the foot. So here is the Urgent PC. Oh, okay. Here is the little sling. It's going right through the mid-urethral part. And then here is that sacral neuromodulator that's implanted. So now my favorite topic, the MonaLisa Touch. So the MonaLisa was initially designed for incontinence, but they found as an added benefit that it led to vaginal rejuvenation. It is a CO2 laser that leads to vaginal regeneration and ultimately a decrease in incontinence. It's not a surgery, so there's no hormones, no cutting, no burning. It's done in the office as an outpatient, and it's essentially painless. There's no need for any anesthesia, although we may use a little bit of topical lidocaine. A probe is placed into the vagina, and a handpiece is used on the vulva. And through the transfer of heat and light, new tissue is formed. New collagen, elastic tissue, and blood vessels. And this new tissue really bypasses the need for any type of topical medication like estrogen. So now there's collagen and elastic tissue and blood vessels on the bladder base, and that decreases urge incontinence. And now the urethra is supported by that collagen and elastic tissue, and it decreases stress incontinence. As an added benefit, the vagina now has new folds in it called rugae that stretch with intercourse. The glands also increase in secretions. And there's that added layer, the glycogen layer, so you have a decrease in both urinary tract and vaginal infections. People have told me that it is life-changing. It is a 5-minute procedure. There are 3 treatments, 4 to 6 weeks apart, and 1 annual maintenance therapy. So I wanted to show you what it looks like. This is a little picture rendition of the probe that's placed in the vagina. This is what the tissue looks like. It's a little hard in here with the lighting, but there's these little, small little areas of microablation. This is the same patient before and after the MonaLisa. Here you can see it's really flat. There's no moisture. These little areas that are red in here are petechiae or trauma. After the MonaLisa, there's nice ridges here that stretch and good mucus production. Again, here is the same patient. They took histological specimens before and after. Again, before, thin, just connective tissue, fibrinous stuff, no collagen or elastic fiber. Here, lots of collagen, elastic fibers, and blood vessels. There are a few people who can't have the MonaLisa Touch. If you have a lesion on your cervix, vaginal area, or vulva that hasn't been evaluated. If you have an active infection, so if you have herpes, we would want to suppress it. I've done a lot of women, I've done over 200 of these. And if you have herpes, that's fine. We just might give you a medication, either acyclovir or your Valtrex prior, so that you don't have an active lesion when we treat it. Women who are pregnant or are 3 months postpartum. However, I have used it on breastfeeding women because this is really a low estrogen state, and they're super uncomfortable with both intercourse and incontinence. If you have significant pelvic relaxation, where the cervix and the bladder are coming down or out the vagina, then of course you're probably too far along, but I have used it for women who have moderate pelvic prolapse, because again, that collagen and elastic tissue are holding up those ligaments. If you've had a history of irradiation to your pelvis, probably not the right candidate. And then if you've had extensive surgery with mesh, so if you've had an anterior or posterior repair where we've put mesh into the vagina, probably not a good idea. But if you've had a sling, sure, no big deal, we can do it. And then if you don't heal well, or if you overheal, something like keloids. But I didn't want you just to use my information, I wanted you to look at the data. So Bagish in 2016 looked at urge urinary incontinence. It is a small study, but 20 out of 23 individuals, so about 87%, had complete resolution of frequency and urgency. No side effects. In 2015, there's a study of 161 postmenopausal women, 45 to 65, and they looked at mild stress incontinence. And they found that 2/3 had significant improvement at 12, 24, and 36 months. And interestingly, this correlated with those histological changes that I showed you. And again, no side effects. The last one here is a review of 13 studies, 818 patients, and 77% saw significant improvement. They actually looked at urodynamics. So if you go to a urogynecologist or urologist, they will probably stick a probe in every orifice you have from here down, and they will look at pressures. And they found an improvement in the flow rate, voiding time, and maximum pressure. And the only adverse effect here was a little bit of irritation for about 2 days, and that resolved. And I found that about 10% of my patients have an increase in vaginal discharge, a little bit of spotting and that irritation, but it all resolves within 3 to 5 days, and we haven't had any long-term issues or problems. So I wanted to give you a few patient testimonies to see exactly what my patients are saying. And one said, I used to have urinary incontinence. After my 3 MonaLisa treatments, I no longer have urinary incontinence. It's wonderful. My vaginal skin is much softer. I would highly recommend the MonaLisa treatments. Another patient noted that Dr. Larson-Ohlsen and her staff are very thorough and attentive to your needs. I recently had the MonaLisa procedure. I have never felt better. The staff and Dr. Larson made me feel very comfortable during the entire visit. The procedure itself has made me feel like a new woman. Complete sensation has returned, no pain with intimacy, and no surprise leaks. This is a wonderful procedure. Thank you, Dr. Larson and staff. So that's the good news. The not so good news is it is not covered by insurance. So it currently costs $2,100 for the 3 treatments and $700 for the annual maintenance therapy. We do have some financing through KeyBank. But if you look at especially topical estrogens, it's really affordable comparatively. So in conclusion, the MonaLisa Touch is an attractive alternative method and maybe the best option for women with mild incontinence who don't want to use medications, intravaginal devices, have invasive procedures, or can't have surgery. But it is not the right procedure if you have severe incontinence or advanced pelvic prolapse. Again, people have told me it is life-changing. So, I do have 4 women here who have actually had the procedure done. So, if you'd like, they can just tell a little bit about their what they've had done and how it was and what happened with that, and then I'll open it up for questions. Thank you.
You're looking at me, do I go?
Yeah, you can go first. Miss Mary.
Do I have to stand there?
Sure.
Doesn't have to.
First person will be just sit.
I don't think she means that.
No, she doesn't need that.
I'm not going to say that much.